Pulmonology burst, part 2. This condition is characterized by an abnormal enlargement of the airways that is due to recurrent inflammation and infection. It's also characterized by large amounts of sputum. What is this? This is bronchiectasis. Anytime you hear about a lung disease that is recurrent and has a large amount of sputum production, think about bronchiectasis. Most common cause of bronchiectasis in developed nations. What is it? Right, cystic fibrosis. And the most common cause of bronchiectasis in undeveloped countries is what? Infectious, that's right. But also know that there are many other causes for bronchiectasis, including airway plugs, obstruction, COPD, tumors, ciliary dysfunction syndrome, chronic bronchitis, and there's several others also. And the symptoms will most often include a cough, sputum, hemoptysis, and fever. And chest x-ray will show thickened airways with parallel lines that some radiologists refer to as this. Do you know? Parallel lines? This is tram tracking. Why are lung infarcts uncommon in patients with pulmonary embolism? Lung infarcts, relatively uncommon in patients with pulmonary embolism. Because? Well, they're uncommon in general because the lungs have a dual blood supply. Most common chest x-ray findings in patients presenting with PE, pulmonary embolism. PE on chest x-ray, most common finding is this. Normal. So most often the chest x-ray will be normal. But you'll also see these. You may see Westermark Sign, Palace Sign, and Hamptons Hump. So what is Westermark Sign? Well, let me ask you this. Is Westermark Sign light or dark? So Westermark Sign is a dark area due to collapse of distal blood vessels, causing a focal allogemia or vasoconstriction. Westermark Sign is a focal allogemia. And what about Palace Sign? So this is an enlarged right descending pulmonary artery that can be seen on chest x-ray. And finally, Hamptons Hump. What is it? This is a wedge-shaped opacification caused by lung infarct that can occur with pulmonary embolism. And why is Hamptons Hump wedge-shaped? Well, the pulmonary arteries have a secondary pulmonary lobule system. So pulmonary arteries have what are known as secondary pulmonary lobules, and these distribute blood in a wedge-shaped segment of lung parenchyma. So when the pulmonary artery infarcts upstream, you get secondary infarct all the way down, and that forms a wedge shape. And why the opacification? So the opacification occurs second to hemorrhage due to the dual blood supply from the bronchial arteries. And that's Hamptons Hump. It's a wedge-shaped opacification. The wedge shape from the pulmonary infarct itself and the opacification from the secondary hemorrhage due to the bronchial arteries. How does silicosis present? Silicosis presents with a dry cough or wet cough? Yeah, a dry cough. So everyone's going to have a dry cough, and it's a progressive condition that slowly gets worse. So it's not going to be intermittent, it's just going to get worse over time. And what about the crackles? So the crackles in silicosis are often described as Velcro sounding, and that sound is pretty classic for almost any type of interstitial lung disease. And what will you see on chest x-ray in patients with silicosis? So classically, you should see widespread nodules measuring about 2 to 5 millimeters in diameter, having a predominance in the middle and upper lung zones. So nodules 2 to 5 millimeters, having a predominance in the middle and upper lung zones. Let's talk about emphysema. How does emphysema from alpha-1 antitrypsin deficiency differ from emphysema due to smoking? Well, with alpha-1 antitrypsin deficiency, you get a panacinar emphysema, and in smoking, you usually get a centrilobular emphysema. So panacinar, also called panlobular emphysema. This is when the entire respiratory acinus, from the respiratory bronchioles to the alveoli, is expanded. And this occurs more commonly in the lower lobes, especially the basal segments, and it occurs with alpha-1 antitrypsin deficiency. Centroacinar or centrolobular emphysema is when the respiratory bronchioles, the proximal and central part of the acinus, is expanded. So the proximal and central part rather than the entire respiratory acinus. So this centrolobular emphysema occurs more commonly in the upper lobes. So panacinar in the lower, centrolobular in the upper. And why does emphysema due to alpha-1 antitrypsin deficiency affect the lower lobes, while that from tobacco smoking affects the upper lobes? Well, this is pretty simple. So in the lungs, perfusion is greater at the bases, and ventilation is greater near the apex of the lungs at the top. Thus, since there's greater ventilation occurring in the upper lung fields, a greater amount of tobacco smoke will go to the upper lung fields. And since more perfusion occurs at the bases, in alpha-1 antitrypsin deficiency, you don't have as much alpha-1 antitrypsin in the bases that you would normally have, and thus the emphysema is more predominant there. How many of Light's criteria need to be positive in order to make a diagnosis of exudative pleural effusion? So how many of Light's criteria do you need? This is simple. It's just one, okay? So what are Light's criteria? So a pleural fluid to serum protein ratio greater than 0.5, a pleural fluid to serum LDH ratio greater than 0.6, or a pleural fluid LDH greater than 2/3 the normal upper limit for serum. Those are Light's criteria, and you only need one to make a diagnosis of exudative pleural effusion.